For clinical ethics, everybody knowing that is having the 4 pillars, including autonomy, beneficence, non-beneficence, justice. These actually apply to all the clinical conditions, not only confined to palliative care. But in palliative care, we also have other considerations when making some ethical decisions, including futility, withhold or withdraw treatment, surrogate decision makers, etc., etc. So what are the principles that we applied in managing patients on palliative care? Firstly, we have to assess the competency of the patient. Now, for competent patients, they have the absolute right to choose whether to consent to medical treatment, to refuse it. It says notwithstanding that the reasons for making the choice are rational or irrational, unknown or even unknown. So once it is a competent patient, they can make the decision by themselves. However, for incompetent patients, including the young children, then the proxy decision-making team, including the patient's next of kin, usually those are the parents, they must reach the consensus agreement regarding a management strategy that is in the child's best interest. Now, I would like to use a case to illustrate both principles and what are the problems that we encounter during patients requiring palliative care but with a lot of ethical dilemma. Now, Charlie Gard is a very well-known ethical case in palliative care. He was born in August 2016 with healthy appearance, and then he was found to have abnormal neurological signs, and then a diagnosis of mitochondrial DNA depletion syndrome was made at Great Ormond Street Hospital 1 month after birth. And then a few months later, as the patient's condition was not improving, the mother started to post Charlie's photo on the social internet. The purpose is try to get the crowdfunding for some form of low-volt treatment that is available in US but not in UK. That is a form of nucleoside. And actually she was successfully raised £1.3 million for this purpose. However, the patient's condition further deteriorated, and then in March, the hospital asked the High Court to rule that life support treatment should stop for the child. And of course, the parents are not did not agree for that. And then 1 month later, the High Court judge rules doctors at Great Ormond Street Hospital can turn off Charlie's life support machine against his parents' wish. So that is the High Court judgment in April. And in fact, these court issues has been lingering on for many months because not only at the High Court and then appearing at the Court of Appeal, Supreme Court, they both upheld the High Court's ruling, and also finally even went to the European Court of Human Rights. At that time, UK is still part of the EU. So all these courts rejects their plea. And in fact, not only affecting the court issues, in the social media, the Pope and the President Donald Trump also expressed their wish to help the child. So it became not only a medical case, but quite a widely spread matter in the social media. And the US doctors later on also participate in the care and then found that the child already had very severe brain damage, so much so that it is irreversible then, and also agreed that the child cannot benefit from the nucleoside treatment. So with these bad news, finally the parents accepted, and then in July the parents withdraw their application to take the son out of UK for treatment and then ending their legal battle. So you can see that in that so many months that the families were actually had been in very difficult situation, had been under great stress from these legal matters. So what did we learn from this case? Now, actually, the hospital and the family had different views on the care of the patient. But what is the best benefit to Charlie? And who make the decision for the best benefit? Actually, these are quite different views from the hospital and also from the parents. Both want to provide the best benefit for the Charlie, but their goal of best benefit were quite different. And also, it seems that the hospital and the parents could not agree on the decision, and then it actually was settled at the court. And in this particular case, why the parents are so keen on trying alternative treatment? Because there was some report of experimental treatment that might help the patient. In fact, this is getting more and more common nowadays, and more so-called new treatment or novel treatments are now introduced in the medical field. Even though these may not apply to many diseases, but some patients might benefit. So it actually gives hope to the family. So in this particular case, if the parents want to try some experimental treatment, and actually they could raise funding from the community, and it did not require any public health budget. So why the hospital or the court were so insistent, so consistent to making the decision not to allow the patients going to overseas for treatment? So finally, some people ask, were the parents actually losing their rights as parents that they could not make the decision for their children? Now, these are the questions that actually well demonstrated in this particular case. Now, actually, this is a case what we call a case with no winners, because his doctors actually want to remove the ventilator to allow the patients to die with dignity, because they know that the patient has no chance of cure and will be running a downhill course, so they would like the baby to die with dignity. However, the parents, on the other hand, want to bring the child to US as the last chance to save his life, even though they understood this is an experimental treatment. So after these long battles, parents finally accepted and agreed Charlie to go. But there's another issue brought up later on, is about the final wish of the parents, because the parents would like Charlie to stay at home and would let go when let go this could not be fulfilled. Why? Because when the mother applied to allow Charlie's return home to die, and then the hospital opposed his plans because they considered the child could not get the specialized care he needs at home, and so they will be at risk of so-called distressing death. That is against the wish of the doctors. And so with this opinion, then the families tried to use the private fund treatment at the hospice. So that it is not at home, so it's slightly better equipped. So the child may be allowed to stay on life support for a number of days. However, the next day the judge orders Charlie to be transferred to a hospital where his artificial ventilation to be removed after a period of time. So that means the court did not want the child to have lingering on the ventilator at a hospice for a long period. So finally, the following day, the Charlie dies in the hospice where he was receiving palliative care, and 1 week just short of his first birthday. So the mother finally, her saying was that the hospitals has denied us our final wish, and the court just gave us very little time with our son. Now that is from the mother's view. So actually the mothers was not wishing the child to be having a long survival, but they just want the child to be having more time accompanying the parents at the hospice. But that was also denied. So that is actually something of great trauma to the parents. So when we look at this case, actually who should make the decision? Now each individual with capacity should be able to decide. However, if there's the patient does not have the capacity to make decisions like this baby, then the third party decision maker will be designated by person or by law. In this case, it should be by the parents. Individual with diminished capacity should be included to the extent of the capacity, not all or none. Now that means even though sometimes we are saying that this is a patient with mentally retarded or did not have full capacity, but we will not exclude them completely from the decision making. We should try to incorporate their views and try to gather what's the best outcome for or what is the best consensus among all the parties involved in the decision making. Now, when we talk about parents in the decision making process, legally and morally, they should be able to give or withhold consent for treatment. It's for treatment. And the decision should be accepted unless it is against the interpretation of healthcare team about the best interest of the patient. So if the parents made some decisions which is against the best interest of the patients, then the child should be protected by somebody else to help these patients who could not make the decision. So in general, the healthcare team will inform the parents and patients, and they should be informed, involved in the decision-making process, with doctors taking the lead in judging clinical factors, while parents will take the lead in determining the best interest. So it is not decided by any single party. It should be a joint decision with all the stakeholders who can make the decision for the best interest of the patients. Now, for medical professionals that we are doing, that what are our role of this kind of decision making? Our role firstly is to inform the patient and family regarding the pros and cons of different treatment approach. Like the pros and cons should be elaborated, and also not only one treatment approach that we consider is the best, but treatment approaches of different varieties, if available, should also be informed to the parents. And then we should evaluate the clinical condition of the patient based on our professional knowledge, and also determine whether some of these treatment options may be of futility. Now, when we talk about futility, there are several types of futility. Physiological futility, if the patient is in persistent vegetative state, or so-called low chance situation, or low purpose situation, or unbearable situation. Now, these will be the factors including into the determination of futilities. And in most ideal case, we are always emphasize we should have achieving a common value with the patient and the family. And then finally, our goal is to let the patient die with dignity. Now, what are the guidelines that are available in hospital authority? In 2015, the life-sustaining treatment in terminally ill patients guideline. There are several situations. I would recommend you to have time to go through this guideline. We actually have been spending quite a lot of effort trying to prepare some scenario. For example, the scenario one, when it is uncertain whether certain treatment is in the best interest of the patient, or when futility or treatment may be considered likely but not firmly established, and family do not accept the futility of treatment. What are we going to do? Now, given that we understand the likelihood of irreversibility of the illness, and also possibility of futility of treatment, and also potential risks and harms of treatment, So are we going to refuse the patient's and the parents' wish? Now, usually in this situation, it's quite difficult to convince the parents to do nothing. So sometimes we may offer a so-called time-limited trial of treatment, so that we have set a well-defined therapeutic goals and endpoints. So after a period of time-limited trial, for example, over 1 week or over a few days, and then we will assess the response to treatment after this period, and then if no progress is made, then the futility is established, and then resolution can then be reached to withdraw the treatment. So we are not refusing the parents right at the beginning, but we take into the consideration of their views, and then we consider is probably having a trial of a limited time. So it is not a kind of unlimited period of trying. That is not really of benefit in making the decision. Now, in another situation when the family requests for treatment, which are not physiological futile, but are considered not to provide net benefits to the patient by the care team. So how are we going to deal with this situation? Usually this may be related to not communicated fully or effectively about the realistic assessment of the patient's medical condition. So the parents may not be fully informed or communicated in these aspects. Now, family cannot appreciate the futility of treatment because when they considering meaningful life expectancy and quality of life may not be taken into serious consideration. And not uncommonly, the family may uphold unrealistic expectations despite communication. So this is not uncommon when we are dealing with our day in, day out cases. So how are we going to do? And so in this situation, we need to have further communication to clarify incorrect information. So we have to discuss with the family to understand why they come to this condition, and also to understand what expectations they are holding, but these may be unrealistic. So we hope that with further communication we may arrive at a consensus, but this may not be easy in some of the situations. Now, in other conditions, when the physiological futility is well established in clear-cut situation, or for example, the patient is already having brain death situation, so the healthcare team is not obliged to provide futile treatment, and families should reconsider healthcare planning of the patient. Or when the family requests all technically possible treatments, though there is no real hope of recovery, then the healthcare sector have the duty to make the best use of resource available. For example, continuing the stay in the PICU for a very long period may not be of the best use of the resources. When there's disagreement between family and doctors, we always emphasize that we need further communication. That means not one communication may solve all the problems, so we have to repeatedly try to clarify the incorrect information or unrealistic expectations. So sometimes we may have to ask help from other colleagues who may be more experienced in handling difficult communication. Communication is something difficult to teach. You may have to get more experience and learn from other more experienced or more competent clinicians who have a better communication skill. If there is still serious disagreement not resolvable after repeated communication, sometimes you may ask for third-party help. That is from a clinical ethics committee, because they are independent committee, including also lay persons from the society. So the ethics committee may act as a mediator as appropriate. And lastly, if the case is still unresolved, and just like the case in the Great Ormond Street Hospital, then we may have to get advice from the HCE, from the HA head office, and then also finally to consider whether we have to apply to the court or not. But that is something we always try to avoid. Now finally, how do we decide? In in the ethical theory, decisions can be based on the belief, the duties, consequences, values, and the rights. These are something we have to take into consideration when we make the decisions. Information should be provided with complete transparency between the decision makers and providers. So if we want to make these parents to accept our proposal, we must have complete transparency. And the informed consent and assent for the decision of care should be obtained. And we must be having a truth telling. And the goals of the treatment should be openly and frequently discussed. Frequently discussed, that means we may need to repeatedly talk with the parents, not at one time, but sometimes several times. Now, for all the treatments that we are talking about, is that required treatment, prohibited, or optional? In reality, all the medical treatments appropriate to the patient's conditions are optional. We call it optional. Exception is that when there is related to control of pain or suffering or treatment required by the public health authority, then these are not optional. Otherwise, all the other treatments are actually optional. That means the patients and the families may decide on what may be of the best interest to the patient. But of course, we also have to balance the harm and benefit to the patient. And the providers should communicate their own beliefs and conflict with the values of the patients. And also the providers cannot substitute their own values for those of the patients, should offer clear recommendations. So we cannot be saying that they allow 5 options, you just choose by yourself. We should provide recommendations based on what belief is to the best benefit to the patient. Of course, the parents and the decision makers are still free to reject the recommendations. And providers cannot abandon the patients because of value disagreement. If they don't agree with us, we still have to provide our continuous care. If necessary, we sometimes have to seek other providers helping them. And however, the providers should not offer or use treatment that are not indicated. And they should also exercise oversight of parents' decision to assure low negligence or low abuse to the child. So when we talk about substituted judgment, deciding for children, the principles is best interest. We have to deal with rational parents, and harm principle is not to do harm to the patients. So for the understanding the best benefit, we have to use our own knowledge, authority, experience, and ethical constraints. For rational parents, the standard requires that the parents prioritize options for the child within a value system that is coherent and consistent over time. Now, this is a table showing that in different situations, when the physician make recommendation, if it is clearly beneficial and the parents prefer to accept, then just to provide the treatment. If parents prefer to forego treatment, but if it is clearly beneficial, we should still provide treatment, but review the process. However, when there is some recommendation which is actually ambiguous or uncertain, if the parents still want to accept the treatment, in that situation, we should also try to provide treatment. But if the parents agree to forego treatment, then since it is uncertain value, then the decision of forego treatment is still acceptable. But when this is a futile treatment considered by the physicians, and the parents still insist on receiving a treatment, like in this situation, quite a lot of the time the people will still provide treatment unless the provider declines to do so. Declines to do so, that means they have to take the responsibility of the subsequent potential action by the parents. But I think if that is having a strong ground, then declines the treatment is still reasonable. But if the parents agree to forego treatment, then forego treatment definitely is the best option for the patient. So in the decision making, it should be guided by the amount of suffering, potential for relief, severity of disability of disease, potential for restoring the function. What is the expected prognosis and the lifespan of the patient, and also the potential for child to experience satisfaction and enjoyment in life, and possibility of developing capacity for self-determination. So we need to seriously document the history of decision making. Sometimes it may take many times. So this is decision making communication tool. So we have to look at the medical conditions, to understand what are the patient's preferences, and we have to look at the quality of life of the patient in the coming days, weeks, or months, and what are the contextual issues. Then what are the discussion points that we have been discussed with the parents or with the patient, and then finally come up with the plan. So these are something we should be included in our decision-making communication tool. So quite a lot of the time when we talk about palliative care, there may be the worry by the parents that are we abandoning the child. So we must be assure the parents that we will continue on the comfort care treatment. It will always be continued. And assure the patient and family that your care is continued even when specific treatments are stopped. Okay? So when we talk about withholding or withdrawing curative treatment, actually morally they are equivalent. Even though sometimes we might have started the treatment, but when it's time to withdraw treatment, actually it's just the same value as a withholding treatment at the start. And we also have to consider that when should treatment be stopped if it is doing harm or no longer benefiting the patients. There are just a situation I want to bring up is about the double effects. The double effects is effects that are morally wrong if caused intentionally, but they are admissible if foreseen but unintended. It's developed long time ago. So there are 4 rules of double effects. Now the 2 effects follows from one action. One is good, one is bad. The action cannot be evil in itself. Okay, so one must sincerely intend the good effect, but not about the bad effect of your treatment option. The bad effect cannot be the cause of the good effect. These are something we have to think about the double effect of any particular treatment. Now, medical futility, that means treatment that do not serve the goals of the patients. They are called futile. There can be disagreement about whether treatment is serving the patient's goal or not, but the effort is try to resolve the dispute should always be attempted. If there is a provider willing to accept the patient so that when there is an agreement, then transfer can be made. So don't hold the patients at the last day if you cannot sort out all the problems. If somebody can take over that it is of best benefit to the patient, we may transfer the patient to the care of another conditions. So the futility can be physiologic, quantitative, and qualitative. And when there's moral dispute resolution, they address specifically how treatment is harming or not benefiting. The goals articulated by patients are generally to be accepted if not physiologically futile. So discuss with the ethics committee of the hospital or hospice programs if necessary. So finally, I'll give you some tips on talking with these sometimes difficult discussions. So we try to alert the patient or family on this ethical issue early in the discussion, and important is to actively listening and help to identify what are the stumbling blocks to agreement, and the interests and harms of the benefits to the patient are more important than the issue who decide. If it is decided by the parents, but if it is of the best benefit to the patient, then the doctor should also agree on that. Active relief of pain and suffering should be provided to all children. And the fringe treatment of questionable value in terms of child treatment to assess their effect if necessary. and how to reach the consensus. So try to involve everybody with the views counts in the dilemma, completely honest, be absolutely rigorous, people making their decision with their heads and their hearts. And so look for the hidden agenda. There's always some hidden agendas. And how to reach consensus, I think most important is to take time. All that is important to make sure that you have time to understand the situation.